recording. All right. Welcome everyone to Comorbidity in Focus, Personality Disorders and Eating Disorders. My name is Lydia Rhino, and I'm the program director here at the Eating Disorder Foundation, and I'm so excited to be sharing the space with everyone here tonight. Our workshop this evening is brought to you in collaboration with the Eating Disorder Foundation and ED Care. I'm going to take a moment to share a little bit about the Eating Disorder Foundation. We're a nonprofit that was founded in 2003 with a mission to be an effective resource in the prevention and elimination of eating disorders through free and accessible education, support, and advocacy. We are a Denver-based organization that is now serving individuals and families both nationally and internationally. I want to thank anyone who made a donation upon registration. We're able to provide these free services because of the generosity of our community. I'll add the donation link in the chat if you wish to contribute. If you have any questions for our presenter this evening, I invite you to use the chat feature to communicate with me directly throughout the workshop. The chat is kept confidential and will come to me directly, and we will save time for question and answer at the end of the presentation, and I will deliver those questions to our presenters. So please feel free, as questions arise throughout the presentation, to just send those privately to me in the chat. We will not be sharing the PowerPoint. However, we are recording, and we will send out the recording as soon as possible. And now I'd like to hand it over to Sarah as Regional Outreach Representative for the ED Care in Kansas City.
Thank you so much, Lydia. Hi, everyone. My name is Sarah Fitzdom-DeLiesel, and I'm one of ED Care's Regional Outreach Representatives. We're really excited to be co-hosting today's event with the Eating Disorder Foundation, and we're so glad you're here with us. For those who may not be familiar with ED Care, we are a privately held organization with more than 24 years of experience supporting patients, families, and healthcare professionals and communities in eating disorder treatment and recovery, with locations across Colorado, Kansas, and Nebraska, and we offer a continuum of care for individuals ages 13 and older, including residential, partial hospitalization, intensive outpatient, and outpatient services. We are in network with most major insurance providers, including TRICARE West, Colorado Medicaid, Healthy Blue Medicaid, and Sunflower Health Plan, helping make treatment more accessible for those seeking support. We are especially grateful to offer residential treatment for adults with Colorado Medicaid, providing an important option for individuals who seek a higher level of care. In addition, we provide free confidential assessments and can assist with housing accommodations when needed to help reduce barriers to treatment and support patients and families throughout the recovery process. For those who are joining, for those who, For those of you joining for our continuing education credit, ED Care is offering CEs through MBCC and APA for mental health professionals. At the end of the presentation, we'll drop a link in the chat to a short evaluation form. Be sure to complete that if you would like to receive credit. Certificates will be sent out within 30 days. Today, we'll be learning more about the intersection of personality disorders and eating disorders. So with that, I'll hand things over to ED Care Kansas City's clinical manager, Kyla Bennett, who will introduce herself and get us started.
Thanks, Sarah. Thank you, Lydia. Thanks so much for having me here. I'm really excited to be here with y'all today. And again, thanks for bearing with us with the technical difficulties. I was telling Sarah and Lydia that I think sometimes my attitude negatively impacts technology, but we're going to try to be positive around it today so that we keep working. My name is Kyla Bennett. I'm a licensed clinical social worker, and I'm the clinical manager of ED Care of Kansas City. I've been with ED Care in a variety of roles for going on 9 years, and I've worked with eating disorders, individuals with eating disorders and their families for the majority of my career, providing individual therapy services, supervision, group therapy services, family therapy. And I'm really excited here today to share a little bit about my passion and about this kind of underdeveloped and maybe neglected topic within the field of eating disorders. So thank you so much for having me. So to get started today, as an introduction to our topic, which is comorbidity between personality disorders and eating disorders, I wanted to just briefly go over the learning objectives, We're going to spend quite a bit of time today reviewing the way that we assess for and diagnose personality disorders. I think many people in this virtual room are probably pretty familiar with how we diagnose and how we conceptualize the various eating disorder diagnoses. But personality disorders, if that's not a background that you come from, it can be a little bit more murky, even though it is something that overlaps so much with eating disorders. So we're going to spend some time with that. And then we're going to talk about the comorbidity between these two classifications of diagnoses. Why is this important for us clinically? How does this impact different presentations? How does this impact different client needs? And then how can we serve this need? And what we're going to do throughout this is we're going to look at this through a critical lens. We're going to understand the impact of bias and stigma, both professionally and personally and on an institutional level, how that impacts these things. And then we're briefly going to touch a little bit on some evidence-based treatment modalities for addressing individuals who are maybe struggling with both an eating disorder and a personality disorder, and how does that impact our clinical practice. So there's the learning objectives listed there if you want to read through those more, but that's a little bit of an overview of what we're going to talk about. And I'd like to, before we kind of jump into the slides, I want to start off with just having us all think about some questions here. How do we know about personality disorders? How do we come by the information that we have about what is a personality disorder? And also, how do people with personality disorders present? So I know Lydia asked y'all to keep yourselves muted, keep your cameras off, but if anyone is willing to share maybe how they know about personality disorders, or more importantly, maybe what comes to mind when they think of someone with a personality disorder, or who comes to mind, that would be great. I know for me, oh, yeah, Tina, Sandy.
Yes, hi, sorry. One thing that I have just come to find over the years is one of the major comorbidities that goes along with eating disorders is based around trauma. That's something that I've learned is a very common bond many of us share. Thank you.
Totally. Yeah. And a lot of times, not only do we see the intersection of trauma and eating disorders, but personality disorders are very closely tied with trauma and PTSD, particularly complex PTSD as well. Yeah. Thank you for sharing. Sandy.
When I think of personality disorders and how they manifest, I think of sort of a dissonance with society norms.
Yes, absolutely. Thank you, Patsy.
We just published a paper on deconstructing the diagnosis of borderline personality disorder from a like a feminist decolonial perspective, and thinking about where the diagnosis actually comes from, and it's the history of the diagnosis and who it actually serves. So yeah, I'm not a fan of the diagnosis at all.
I would love to read that. That sounds very interesting. And I have a lot of thoughts about that as well. Thank you, Sandy. Yeah. And I think it's so hard for us to separate out like the information that we first get about personality disorders and maybe that we see in the media and that other folks maybe who aren't clinicians get, versus then what we come to know as clinicians as we're learning more and as we're encountering clients who maybe are struggling with these things. Yeah. How is that different or the same than who we picture having an eating disorder, or how we come to know about eating disorders or individuals struggling with eating disorders?
I think a lot of times eating disorders are such an isolating secret behavior that many times people on the outside don't know that there's some kind of disorder or disordered behavior.
Mhm. Yeah, absolutely. We tend to think of eating disorders as very internalizing versus I think personality disorders, at least in more popular media, are very much seen as an externalizing diagnoses. Yeah. I really appreciate everyone sharing. I like to just ask these questions to get us thinking about what it means to examine the intersection between personality disorders and eating disorders, and also for us to just be aware of our own frame of reference, both personally and clinically, and how that impacts how we present in the room with clients, maybe who are struggling with a personality disorder or an eating disorder. I chose a few media representations of personality disorder. Some of these are more recent representations. Some of these are a little bit older, Fatal Attraction. But anyone recognize these? They're pretty intense. So a lot of kind of what is put out into the world about someone with a personality disorder diagnosis is framed in a very particular way, and it's kind of an intense representation. We've got most recently they did a TV show on Jeffrey Dahmer that's in the lower left-hand corner, and they made kind of a big deal about in the TV show him being diagnosed with borderline personality disorder. And then Fatal Attraction as well with Glenn Close, if we've seen that. Borderline personality disorder diagnosis, a very intense representation there. On the upper left, we've got American Psycho, which has kind of been deemed as a representation of narcissistic personality disorder. And then in the top right, which is where, as a very young person, I first got my first exposure to the media definition of a personality disorder. We have Girl Interrupted, with Susanna Kaysen, the main character, having borderline personality disorder diagnosis, and Lisa having an antisocial personality disorder diagnosis. So just some things to keep in mind as we move forward throughout our presentation today. I know you all mentioned personality disorders are highly culture bound. So what is considered abnormal in one culture may be accepted and even expected of us in another culture. And so this means that the way we conceptualize and define what is personality and what is a disorder is going to change over time and space. And so understanding that our frame of reference may not be one that our clients share, and that's going to impact maybe how they think about their struggles and behavior versus how we think about it. We also know that personality disorders are frequently conceptualized and diagnosed on the assumption of certain cultural expectations and also on the assumption of a gender binary. And as a result of this, personality disorders are often frequently diagnosed, maybe overdiagnosed in certain demographic populations, and therefore may be overrepresented in these certain groups. Some examples of this: borderline personality disorder and histrionic personality disorder are much more frequently diagnosed in female identified individuals than male identified individuals, whereas antisocial personality disorder and narcissistic personality disorder are more frequently diagnosed in male identified people. We know that antisocial personality disorder is something that is diagnosed much more frequently in individuals of color, particularly in correctional settings and prisons. And we also know that individuals who are in psychiatric settings are more likely to be diagnosed with borderline personality disorder. And so when we're thinking about how do we assess clients for this and how do we address the comorbidities of a personality disorder with an eating disorder, we want to keep this in mind. We also know that personality disorders are very highly stigmatized. In fact, it's shown that they're one of the most highly stigmatized mental health diagnoses out there. And even experienced clinicians, psychiatrists, nurses, social workers, therapists demonstrate levels of professional bias towards people with with personality disorders at higher rates than they do individuals with other mental health diagnoses. And I can't help but think that that has something to do with maybe some of the media representations that are in our population at large, and then also the conversations that we as clinicians are having with each other. So throughout this conversation, this presentation, I would invite you all to be aware of your own implicit and explicit biases, your own culture, your own understanding of gendered expectations, and how this impacts your clinical practice, and more specifically, your understanding of personality disorders and eating disorders. I think that's one of the most powerful tools we have as clinicians, and also one of our obligations as clinicians to be aware of that. So thank you all so much for participating there. Depending on who you are, you may love this book, you may hate this book, you may hardly use it, you may use it all the time, but this blue book here is the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition text revision, the DSM-5 TR. And as of now, this is where we get our framework for identifying and diagnosing personality disorders. There is a lot of flaws in this material. We could probably have a whole presentation on bias within the DSM, structural problems with using this manual. And that is beyond the scope of this presentation, as much as I wouldn't like it to be. But what I will say is that assessing personality is controversial, it's complex, and it requires lengthy evaluation. So no assessment of someone for a personality disorder would likely happen in a short-term setting or in a small period of time without really getting a full picture of what is going on for the person. And that is so important to recognize areas of trauma, areas of culture, areas of life circumstance that all could play a role in how personality is thought of. And I wanted to bring up that there is an alternative model for diagnosis and conceptualization of personality disorders that has been proposed by the American Psychiatric Association. There's actually a special personality and personality disorder work group that has been working on this new proposed model. And that model, very briefly, it involves things like cutting out certain diagnoses, like histrionic personality disorder, for example, and molding more of the current personality disorder diagnoses together. Again, we could probably spend a whole presentation on the new proposed model for assessing and conceptualizing personality, but we cannot. So for the sake of this presentation, we're going to focus on the currently accepted diagnostic criteria and the currently understood ways of conceptualizing personality for our clinical practice. But just know that it is controversial, so much so that the APA itself is thinking of other alternative models. So I want to spend some time talking about what is a personality disorder or a PD? How is that defined? What criteria are we looking for more generally? And then going into a little bit more specifically the different clusters and groupings of personality disorders, so that when we talk about comorbidity with eating disorders and which diagnoses are most common, how that impacts clinical presentation, we have a bit of an understanding. And this comes directly from that ambivalent, sometimes good, sometimes evil book, the DSM-5 TR. And when we're talking about a personality disorder, we're talking about an enduring pattern of both inner experience and external behavior that deviates markedly from the expectations of an individual's culture. So again, we cannot separate an individual from their environment and what is expected in that cultural milieu. The pattern has to be considered both pervasive and inflexible, meaning that it occurs across all areas of someone's life, and that it is relatively stable over time, meaning people don't experience kind of like a depressive episode, maybe periods of heightened symptomology and then it reduces and so on and so forth, but rather it's relatively consistent and it impacts a lot of different areas of someone's life. So if someone is just struggling or demonstrating dysfunction in like their work life, but not at home, not in other areas, it wouldn't be considered pervasive. And the patterns of a personality disorder are manifested in at least 2 of 4 ways. And those ways are cognition, so thoughts and thinking patterns, affectivity, so emotions and affective response and how that's displayed and demonstrated, interpersonal functioning, so socially with loved ones, with friends, in other social settings like work, and then in impulse control. So that's where we start to look at things like behaviors and whether behaviors are impulsive, compulsive, restricted, etc. Typically with personality disorders, it's also required that you see an onset or at least some signs or symptoms of this in adolescence, if not early adulthood, although diagnoses are not typically made until adulthood, at least the age of 18. That is because anyone who has been a teenager or has teenagers in their life knows that personality is still very much in flux, as is that prefrontal cortex is growing. And so it's really hard to understand if a personality feature is pervasive and flexible at a young age. So you would definitely expect to see signs of this early, but the diagnosis would not be made until later. So we're going to go into perhaps the most controversial part of personality disorder diagnosis, at least for me, and that is how personality disorders are grouped or clustered. And currently, the DSM has personality disorder diagnoses grouped into 3 clusters, and they call them cluster A, cluster B, cluster C. And you might even hear that in layman speech or conversation between clinicians about different personality disorders, like, oh, that's such a cluster B trait, if anyone's ever heard something like that. So the personality disorders are grouped currently in a way that is based not on anything that's really strongly research-based or has demonstrated validity in the groupings, but rather they're based on descriptive similarities. And when we dive into these descriptive similarities, you will see that they are not strength-based at all. So as we're kind of going through these, I would encourage you all to sort of pay attention to what that brings up for you, maybe hearing how some of these clusters are described or talked about. But there's 3 main clusters that are grouped based on these similarities. And then there's 2 other diagnoses that are not included in these clusters that when you're making an assessment of a personality disorder, you would definitely want to rule out. And one is personality change due to another medical condition. And that refers to any sort of organic or biological medical cause that could be impacting someone's personality or causing a personality change. We know certain brain injuries, traumatic brain injuries, brain lesions can cause personality changes, can cause someone's maybe behavior to deviate from what is expected from their culture. We also know certain infections like neurocognitive disorders, dementias, HIV, AIDS, Huntington's disease can cause personality changes. So whenever you're doing an assessment for a particular personality disorder, you'd certainly want to rule out an organic cause as well. And then there's, as with a lot of diagnostic chapters in the DSM, there's other specified or unspecified, which are diagnoses typically used when there is not enough information to really get a clear clinical presentation, or when someone maybe doesn't fit into just one diagnosis or category. So I'm not going to go over the diagnostic criteria for each diagnosis here. Again, we could probably spend a presentation on each of the 3 clusters themselves. And I do just want to briefly go over the diagnosis within each cluster and what each cluster entails. So here we go with the non-strength strength-based language. So cluster A is what is considered the odd or eccentric cluster. So these personality disorders are marked by behavior that would be considered odd or eccentric based on cultural expectations of an individual. So this includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. This category can be challenging because a lot of times it can be difficult to not conflate schizophrenia, schizophreniform disorder, and these are separate personality disorders, again, enduring pattern of pervasive dysfunction versus a psychotic disorder like schizophrenia. So that's just a very small blurb. This is directly from the DSM about each of these personality disorders in cluster A. We're going to spend the majority of our time looking at cluster B and cluster C because that is where the highest levels of comorbidity with eating disorders have been found in the research. So cluster B, again, not strength-based language, is considered the dramatic, emotional, or erratic cluster. So disorders in this cluster, again, would be deemed as having traits that are overly dramatic, emotional, or erratic based on what is expected of an individual's cultural milieu. So here is where you'll see antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. Borderline personality disorder, there is a star next to it, and that is because this tends to be one of the more researched personality disorders, and we'll talk a little bit more about that as we move through, especially when we get into the specific comorbidity. But borderline personality disorder, or BPD as it's sometimes called, is a pattern of instability in interpersonal relationships, self-image, affect, with marked impulsivity. So we're going to talk a little bit specifically about that one, that diagnosis as it relates to eating disorders as well. Borderline personality disorder and histrionic personality disorder, as I mentioned before, these tend to be heavily diagnosed on a gender binary and are sometimes associated with what is considered stereotypical feminine traits. And so there's a lot of criticism and debate surrounding that. Also, all four of these diagnoses are often heavily associated with trauma and adverse childhood experiences. So an impact of somebody's childhood or traumatic experiences cannot be separated out from these diagnoses. Then the last cluster is cluster C, and this is the anxious and fearful cluster. So diagnoses in this cluster, again, individuals would exhibit behavior that would be considered more anxious or fearful than it would be expected for someone's culture in a similar situation. And that includes avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. As you'll see, obsessive compulsive personality disorder, OCPD, is starred because that is another diagnosis that has been shown to be pretty heavily comorbid with eating disorder diagnoses. And that is defined as a pattern of preoccupation with orderliness, perfection, and control. So I think a lot of times when people say, oh, I'm so OCD, they're not actually talking about obsessive compulsive disorder, which is in a different classification of diagnoses, but rather they're talking about having a more obsessive compulsive personality. So it is distinct from OCD, even though there can be some overlap. It is a distinctive diagnosis, and the two can be mutually exclusive. So we're going to talk a little bit more about that in relation to eating disorders as we move forward as well. So those are the clusters, not very strength-based language. Again, there's a lot of criticism about it, a lot of conversation about, is this the right way to classify these? Is this in best service of patients and clients? And so if you're thinking that yourself, you are certainly not alone. And I think clinicians, we have some power in how we change that. So Eating disorders. I am not going to go through the diagnostic criteria or the different clinical features of these eating disorders. I think that's probably something many of us in this room are more familiar with. But when we talk about eating disorders today, we're talking about really the whole length of diagnoses, in particular anorexia nervosa, bulimia nervosa, binge eating disorder, avoidant restrictive food intake disorder, or ARFID, and then OSFED and USFED. Before I move into some of the research that exists on comorbidity, I do want to point out that in a lot of the research that I did for this presentation, it was very hard to find information on ARFID. ARFID is a newer diagnosis, as many of us know, newer in terms of, not that people haven't been struggling with it. I think people have been struggling with ARFID for a very long time. And it's a newer classification of diagnosis in terms of the DSM and in terms of the APA. So that's an area that I think could probably be studied more. Is there an intersection between personality disorders and ARFID? If so, what is that? Another reason we may not see as much research there is because ARFID is the typical age of onset for ARFID is younger, and we know personality disorders, it often is considered best practice to not diagnose before the age of 18. So either way, I'm not sure exactly why that is the case, but it was hard to find information on ARFID. And so that's an area kind of a future interest, at least of mine, that I think we could go in terms of understanding and researching that comorbidity. And then also, I just want to point out a lot of the research that's I found was relating to anorexia nervosa, bulimia nervosa, and sometimes binge eating disorder. There was very little on other specified feeding or eating disorder or OSFED. I think many of us in clinical practice know that OSFED is actually probably the most commonly diagnosed eating disorder, just because it is so challenging for an individual to meet all of the specific diagnostic criteria for the other disorders. And so I think that's another area where we maybe have some gaps, and it would be interesting to find. So just a little primer there. When we're talking about this research, often it relates to anorexia, bulimia, and binge eating disorder. There's not as much on ARFID or OSFED there. So moving into the whole point of this presentation is comorbidity. What is the intersection between eating disorders and personality disorders? And the first kind of question is how much of how much of a concern is this? How prevalent is the intersection between EDs and PDs? And I found lots of different articles with varying kind of counts, but typically speaking, the psychiatric comorbidity between eating disorders and personality disorders is estimated to be anywhere from 30% to 70%. So that means up to 70% of people diagnosed with an eating disorder may also have a comorbid personality disorder. Studies suggest that certain eating disorder diagnoses are more heavily comorbid with certain personality disorder diagnoses. In particular, I mentioned borderline personality disorder and obsessive compulsive personality disorder are the diagnoses shown to have the highest comorbidity with eating disorders, but that comorbidity varies. So individuals with bulimia nervosa are more likely to be diagnosed with a cluster B personality disorder, particularly borderline personality disorder, and individuals with anorexia were more likely to be diagnosed with a cluster C personality disorder, particularly OCPD. So there's a couple of ideas about why this might be. And in fact, here's some research about it. 22% of individuals with anorexia nervosa restricting type, ANR, may have a comorbid diagnosis of OCPD. So OCPD symptomology is present in approximately 22% of individuals with ANR. This is in comparison to a prevalence rate of about 8% of OCPD in the general population. In contrast, as many of 25% of patients with anorexia nervosa, binge eating purging subtype A and BP, and 28% of patients with bulimia nervosa meet diagnostic criteria for a BPD diagnosis. So that is compared to a rate of about 6% prevalence of BPD in the general population. So there are a couple of reasons why this might be. There's sort of a belief that the frequency of these comorbidities and the variance of these different diagnostic comorbidities might be attributable to similarities between the personality traits that are associated with eating disorder development and eating disorder vulnerability and the diagnostic features of a personality disorder. So, for example, there have been a lot of studies on temperament and personality in individuals with eating disorders, specifically to identify, are there personality traits that make someone more vulnerable to developing an eating disorder? And in particular for anorexia nervosa restricting type, personality traits such as perfectionism, restricted emotional affect, maybe more fearful presentation, hesitancy to take risks. Those are traits that are associated with vulnerability for anorexia. Those are also traits, as you may have noticed when we were talking about an OCPD diagnosis, are pretty congruent with a lot of the traits of OCPD, in particular perfectionism, cognitive rigidity, right? Same thing with borderline personality disorder and bulimia nervosa. Individuals diagnosed with bulimia nervosa, personality traits that are associated with that vulnerability are more risk-taking behaviors, more under-controlled emotionality, high association with comorbid trauma and PTSD. And those are all things that also can be associated with a BPD diagnosis. So there still is a lot of room for research there. And again, I don't think we can rule out the impact that bias, that stigma has, the impact that trauma and ACEs have here. And they think that this comorbidity and the variances in it can be attributed to some of the similarity overlaps in the personality features that support both eating disorders and personality disorders. And this is important for us to pay attention to because individuals with eating disorders and personality disorders demonstrate more severe functional and social impairment than their peers without a comorbid personality disorder. Again, this could be attributable to trauma. This could be attributed to lack of understanding and stigma from professionals. But having both a personality disorder and an eating disorder is associated with more functional and social impairments. Individuals with both a comorbid eating disorder and personality disorder are also more likely to have additional comorbid mental health diagnoses, including depressive disorders, etc. So it is very important to understand that individuals with a high level of comorbidity or both of these diagnoses may be more vulnerable than their peers. It's also shown that high levels of cluster B personality disorder symptoms, so individuals with BPD or histrionic personality disorder, tend to have poorer treatment outcomes or more struggles to reap benefit from treatment than their peers without a comorbid personality disorder. And again, this could be related to issues of fit in eating disorder treatment that doesn't address comorbid eating disorders. It could be related to bias, etc. And more specifically, we've seen that individuals with a comorbid eating disorder and personality disorder, their symptomological course is more chronic, meaning they tend to struggle with symptoms of both an eating disorder and personality disorder for longer. And so that makes treatment more complicated and challenging. And then we know that stigma also is associated with poor mental health treatment outcomes. Individuals who face high amounts of stigma from mental health professionals, self-stigma, and then also larger societal stigma are less likely to seek treatment in a timely manner, and are also less likely to feel empowered to remain in treatment and adhere with treatment guidelines. So this comorbidity is definitely something that we as eating disorder professionals need to pay attention to. So what do we do with this? What are the treatment options that are available for individuals with an eating disorder and a comorbid personality disorder? We all know that eating disorder treatment is multidisciplinary and often requires treatment from doctors, therapists, dietitians, might even include family therapists, group therapists. You might have psychiatry there. You might have case management there. You might have experiential therapies like yoga, music, art is part of this treatment process as well. And all of that is still very much true for individuals with comorbid personality disorders. And there are ways that treatment can be adjuncted, supplemented, and modified to better serve the needs of the population with these comorbidities. So right now, the most evidence-based treatment for personality disorders and individuals with personality disorders and comorbid eating disorders specifically are DBT, dialectical behavioral therapy, and RODBT, radically open dialectical behavioral therapy. I'm going to go into each of these a little bit more in depth in the coming slides. And I come from a DBT background. I'm intensively trained in DBT. So that's really where a treatment modality that I love. So I'm going to try not to be biased with these other modalities. But another thing that's incredibly important for treating eating disorders and comorbid personality disorders is trauma therapy, right? Again, we've touched throughout this on the impact and the intersection of trauma with both eating disorders and personality disorders. And so oftentimes trauma-specific therapy is part of the process, whether that is done in tandem with treating the eating disorder and the personality disorder, or whether that is sought after an individual completes a higher level of care, reaches some stability, and then can focus on the trauma care. Either way, that's an important piece of it. And options there, we're probably familiar with ERP, CPT, PE, EMDR, a lot of different options there. Adjunctive medication management. We know that eating disorders and personality disorders, for eating disorders, there may be some medications that are very clinically indicated or demonstrated effective in reducing symptomology. For personality disorders, it's more about alleviating the symptoms or alleviating maybe the comorbid symptoms. So if there's depression or anxiety present, but that can certainly be a part of it. And that's why it's so important to have that multidisciplinary team. And then also psychosocial stress reduction, life skills, case management, which I think is something that can be beneficial across the board for so many people, can be a really important part of this treatment, especially when we're thinking about people as a whole and we're not wanting to just take a medical or a problem-based model towards individuals, looking at the resources they have in their life, the opportunities that are available to them, and how can treatment be expanded to include consideration of those things. So moving into dialectical behavioral therapy, and specifically, how does DBT help individuals in eating disorder recovery? DBT, dialectical behavioral therapy, was created by Dr. Marsha Linehan back in the 80s and 90s, specifically to assist people with borderline personality disorder. And since then, it has really become kind of the gold standard for treating personality disorders and has been expanded to treat so many other concerns individuals may have, including eating disorders. So what DBT can help with is it can help decrease high-risk behaviors such as suicidal ideation, self-harming behaviors, which can be a diagnostic feature of BPD, but also can be something that's very commonly seen in individuals with eating disorders as well. And it also works to decrease behaviors that interfere with quality of life. And this could include eating disorder behaviors like binging, purging, self-harm, rigid food rules, etc. DBT also can address cognitive rigidity by focusing on the dialectic of validation and acceptance with also change and modification of behaviors. And it can promote mindfulness. Mindfulness is a module within DBT, which we know is something that can be very beneficial for individuals struggling with a lot of different concerns. And it also focuses on the acquiring of behavioral skills. So it can help people with that social functioning. So we know individuals with BPD and comorbid eating disorders are shown to have lower rates of social functioning. And so acquiring behavior skills such as boundary setting, assertion, effective communication can really be beneficial there. In particular, a lot of research has focused on addressing BPD with individuals with bulimia nervosa and anorexia binge purge type, and DBT has really been kind of considered the gold standard for some of those disorders that are classified as maybe under controlled or related to a lower level of emotional control. RODBT was designed sort of as the opposite and has really been emerged as a very promising treatment option for those disorders that are considered over-controlled, high levels of perfectionism, cognitive rigidity. So individuals who have anorexia nervosa, who go into RODBT treatment, it's been demonstrated that they have higher levels of treatment adherence and satisfaction than their peers that don't receive RODBT. And it also has been shown to promote weight restoration, which is something that can be particularly challenged in individuals that are undernourished. It also addresses over control, works to increase psychological flexibility, helps to address kind of that over cautiousness or lack of risk taking or extroversion by promoting a little bit more cognitive appraisal there. And in that way, it's very congruent with addressing some of the symptoms of anorexia nervosa and OCPD simultaneously. Now, we all know that eating disorders, they may require higher levels of care, inpatient, residential, partial hospitalization, intensive outpatient. There are some programs that have DBT or RODBT baked into their eating disorder program so they can better address the concerns of individuals with comorbid ED and personality disorders. And it is also something that a patient may have to do kind of one at a time. They may have to do eating disorder, higher level of care, and then once they have weight restored or received an accurate, appropriate amount of symptom interruption, they may then be able to go to an outpatient DBT program or RODBT program. So kind of depending on the client on a case-by-case basis, this may be something that can be done simultaneously, or it may be something that has to be done kind of one after the other. And that really depends on like the patient's medical stability, the patient's needs at that time. And then focusing on outpatient aftercare, there are whole DBT and RO-DBT programs that include individual therapy, group therapy, phone coaching, clinician consultation. And so an individual may graduate from a higher level of care or from eating disorder treatment to a program like that. And that doesn't change the need to kind of continue to focus on eating disorder relapse prevention, maybe continue to have an outpatient dietetic care, medical care, etc. So these are kind of the stereotypical aftercare sort of necessities we think of for an eating disorder. With an individual with the comorbid personality disorder, we may include, you know, an adjunctive DBT program, an RO-DBT program, some specialized care that could provide services for both of those diagnoses simultaneously or kind of in a combined sense. Here are some resources. I see I'm rapidly running out of time and I want to leave room for any questions there might be. Here's some resources on eating disorders as well as some resources on personality as well. And a little bit about ED Care. I won't get into it because Sarah did a great job, talked a lot about us. But we do have locations in Denver, Kansas City, which is where I am, and then Omaha, Nebraska as well. Our programs do have DBT and RO-DBT groups, kind of depending on the locations. So we frequently treat individuals with comorbid eating disorders and personality disorders, and we really believe in sort of addressing all of those simultaneously. And if an individual needs more of a specialized treatment after they complete our program, that's something that we help them find their way to. So. Okay, thank you all so much. Are there any questions?
Beautifully, beautifully done, Kyla. Thank you so, so much for your time. I know that as soon as we start to notice the time and we're like,
Yeah.
oh no, it's dwindling.
Oh my gosh. Yeah.
It's always the worst. So thank you so, so much. You did phenomenal with our little late start. So thank you so much. This is a beautiful presentation and beautiful content that I feel like is often overmissed in our field. We often, I feel like, don't talk about the intersection of personality disorders. And it's something that I know that when I started my work in the field, I felt like I got, even like the education that I got on it felt stigmatized. So it's been something that I've been like deconstructing over my time. And it's always just really grounding to be reminded of like roots of things and how we can best support folks that are navigating different struggles along the way. We do have a few questions. I know that anyone that needs to tap out right at the hour, we're coming up on that, but I really have at least a couple that I would like to get to you.
Yeah.
All right. So first question, what are the best assessments out there that we could use for BPD and OCPD? Any that can be more insight building for the individual rather than further stigmatizing. This individual is coming from a lens of how diagnoses can help someone seek appropriate treatment. And sometimes symptoms seem so egocentric for that individual that they cannot see some of their symptoms as problems, like perfectionism, avoidance of risk in OCPD.
Absolutely, absolutely. And that is a really challenging thing, particularly when for any diagnosis, we've got symptoms that are very egocentric and people may not have the insight into the impact that this is having on their lives. For me, one avenue that I like to take and have found a lot of success in is simply being very transparent with clients and actually like sort of like demystifying the DSM a little bit. Like I'll actually say something like, hey, I know you've said like you feel stuck. Like people are telling you this is a problem in your life. You feel it sometimes, you don't feel it other times. You feel like this is a really big problem in your life. A lot of different clinicians have given you a lot of different diagnoses. And I was thinking about this concept of borderline personality disorder or obsessive compulsive personality disorder. And I kind of wanted to just talk to you about it. And I'll actually take out the DSM. I'm looking up there because my DSM's on my shelf, but I'll actually take it out and I'll kind of go through the diagnostic criteria with them. And I'll ask them like, does this sound like something that resonates with you? Does this sound like something that you've gone through? And I'll actually tell them that for I'll tell them what we talked about in this presentation, that a lot of times these personality disorders are stigmatized. They don't need to be. It can be a way for people to feel like they have some answers. It can be a way for people to sort of get a sense of understanding, maybe some of the things that have been really hard for them and the people in their life that they've missed before and kind of felt like there was gaps in the care they were getting. And I've had that be a really sort of receptive, like something that people are really receptive to in my practice, is just kind of laying it all out there and going through that with people. And not only is that sometimes helpful for them in building that insight and feeling like they have agency in the diagnoses and things that go into their charts and happen in their lives, but it also is good information for me. Obviously, assessment tools, the MMPI, the Minnesota Multiphasic Personality Inventory, is kind of considered the gold standard of measuring personality traits that are associated with various personality disorders, particularly BPD, OCPD. And this really looks at, I mean, it's a long inventory. You have to go to a psychologist, get sort of like go through that special process of it. They made us take it in grad school, so I remember going through all of it. But that, if you have a client that you think could really benefit from a specific honed in assessment of different personality traits and how that may or may not be leading to a personality disorder diagnosis, seeking like psych assessment and getting the MMPI is always an option. And another thing I like to do with clients that I maybe think could have OCPD is I also like to go through the Yale Brown scale, which is meant to measure obsessive compulsive disorder. But I find doing that scale can sometimes be a helpful way to rule that out and make sure that there's no conflation of an obsessive compulsive disorder versus an obsessive compulsive personality disorder. So those are a few things that I have seen and would recommend. There's not a ton of research on that. I think that's definitely another area that would be good to explore more.
Well, I appreciate that. No, I always think it's really helpful to hear, like, from your experience, what's been the most helpful approach with it. And I do think what I've heard too from folks within our community, that it's really helpful to have like the demystifying part of it and have someone just say, especially from like a clinical role, someone say like, hey, I know that this may have been like stigmatized before, or you might have heard narratives around this, and I want to clear that up, and like, let's walk through this together. Sounds much more approachable rather than like here's something that you may take and read and have it feel like maybe doesn't land as well. But I can imagine going through, especially like the DSM, and just looking and be like, does this feel like you? Does this feel like it connects?
Yeah.
And having that be exploratory. Well, also I like hearing too that there's like with one of the inventories that you can kind of use it to rule out. That's helpful
Yeah,
to use as like a
absolutely.
different, like a different way to evaluate that. Oh,
Absolutely.
fabulous. I love that.
Another thing I always tell clients with that conversation is just the impact of trauma. Like, we almost can't separate out a BPD diagnosis from a potential complex
Yeah.
PTSD diagnosis, and just validating that experience. Like, this may just be an impact of trauma in your life, and not due to something that is scary or stigmatized or looks like Glenn Close and Fatal Attraction here, but rather, an impact of kind of severe and persistent trauma and chronic invalidation as well.
Oh, I really appreciate you bringing that up, because I do feel like that can easily be something that gets like missed along the way, or like I don't know how new CPTSD is, but I've heard of it more recently. So I was like, I wonder how many of these things have been interchanged or misdiagnosed throughout time, and how much more clarity we'll see as we continue to get more research. Always my hope is that more research is on the way for our field and more funding will come towards us so that we can continue getting more, so we can help more folks. I know we're a little over. I kind of want to sneak in one more question. Are you good with one more?
Absolutely.
Cool. Are there any personality traits that you've seen become strengths in long-term recovery, even if they initially contributed to illness maintenance?
Oh yeah.
Isn't that cool?
I'm a firm believer that any of our personality traits have dark sides and light sides. I think everyone knows Esther Perel, the famous couples therapist. She talks about how a lot of times the qualities in our partner that we fall in love with end up driving us nuts in 20 years, right? Like that super fun person that is the center of attention, life of the party, 10 years from now, when you want them to sit down and do your taxes, it's driving you crazy that they don't want to sit down and be serious. And I think that's so well said. And I think we can apply that to ourselves as well. A lot of the personality traits that cause a lot of pain, for example, maybe being highly sensitive, maybe being very affectively impacted, very sensitive, very attuned to the needs of others. That is something that can be such a gift. Empathy and compassion is such a wonderful gift, and left unchecked, it can cause us tremendous pain. And so I think that when I think of BPD, I think affective instability is one of the diagnostic criteria there. And oftentimes in my clinical experience, individuals with BPD, they're just so highly attuned, so empathetic to the emotions and needs of themselves, but also that of other people, which when harnessed, when known, like how we can manage that, how we can protect our sparkle and share it is such a wonderful thing. And it can be something that really can impact us negatively, can lead to things like emotional dysregulation, emotional flooding, and all of those behaviors that we lean on when we feel flooded, right? With OCPD, perfectionism brings people so far in life. It's a trait that's associated with so much success, and it can also be sort of a prison of our own creation, and we can get into a cycle where we can't get out of it. And that's why we see so many people, particularly with OCPD, who may be what we would consider very high functioning or successful in life, right? And the inside, there's so many social, emotional struggles that may be going on behind closed doors. So when I'm having these conversations with clients, I try to frame it like that, like all of us, it's a spectrum, but all of us have personality traits, some that we're really proud of, some that we maybe bother us, we wish we didn't have. And I think we can harness like the positives and the negatives of each of those, and it exists within all of us at all times. It's just about having the skills to be able to do that.
That's so beautiful. I love that, like viewing it as like a continuum and being like, yeah, like wherever we're at with it, like can we like work with our personality traits and things to help us be like reaching our level of success, however that looks in our life and however we define it. I really like using the terms like skilled and unskilled for me, like with those kind of things, because I'm like, that leaves room for us to be like, oh, I can practice skills to get myself from the unskilled category of my whatever I'm struggling with over to my skillful side. And it's so much more helpful, I feel like, and less stigmatizing again to use that kind of language instead of being like, oh, these are just negative traits that you might have. It's like, how can we see the different parts of ourselves that do like contribute to our like disorders, whatever we may be experiencing, but how can we also use those to be part of our recovery and to help influence that? I often think about that in my own recovery, being like, yeah, like the perfectionism that I have in some areas that like were part of my eating disorder, like have been able to be shifted into other areas of how I show up, which I've been able to actually utilize to help me be like well-rounded in other areas. So I always think that's a helpful question, and just especially as it relates to disordered eating, to personality disorders, any of these areas where I feel like people still have stigma around, being able to open that up and be like, okay, there are traits that we have that can be beneficial, and we can learn skills, practice them to be able to be more adaptive. So, beautiful. Kyla, I so enjoyed this. I enjoyed your presentation. I enjoyed the questions. And just thank you so much for spending your evening with us here at EDF and with the EDF community. Everyone, please keep a lookout in the next few days to get a notice when the recording is posted and for next steps for CEs. And thank you again, Kyla, for being here. Really appreciate your time this evening.
Thank you so much. It was really a pleasure.
Awesome. All right. Take care, everyone. Thank you.